A very good morning from wherever you're joining us. Welcome to this special talk show where we shall be sharing information as part of activities to mark 1st December, World AIDS Day. The topic for discussion this morning is Equalize, in line with the theme by the World Health Organization that has been set for 1st December, World AIDS Day. We are discussing inequalities in access, quality and sustainability of service delivery. I am Chris Higenyi and I'll be moderating the show. Just a preamble before I introduce my guests. The global HIV response is in danger. Even as HIV remains a major public health issue that affects millions of people worldwide, over the last few years, progress towards HIV goals has stalled, resources have shrunk, and millions of lives are at risk. Division, disparity, and disregard for human rights are among the failures that have allowed HIV to become and remain a global health crisis. Joining me to help us understand the dynamics at play and what stakeholders are up to in the fight against the disease are Dr. Kaziwe Andrew. He's a Principal Technical Advisor, Medical Services at the AIDS Support Organization. Dr. Andrew Kaziwe is an internal medicine physician and healthcare management specialist who works as the Principal Technical Advisor. As I've just mentioned, he holds a Master's of Medicine in Internal Medicine from Makerere University, a Master's in Hospital and Health Management, as well as a Bachelor's in Medicine and Surgery. Many thanks for joining us, Dr. Andrew Kaziwe.
Thank you very much, Chris, and good morning, viewers.
And Dr. Mia Yunus is the Chief Programs and Capacity Development Officer at the AIDS Support Organization. He's a program leader and public health practitioner with more than 10 years of experience in design and implementation of robust public health programs spanning the areas of HIV, tuberculosis, as well as malaria. He's the Chief of Programs at TASO Uganda and oversees the implementation of several bilateral and multilateral donor-funded projects. So no doubt we shall be hearing a lot when it comes to what stakeholders are describing as stalled funding for HIV interventions across the globe. Many thanks for joining us, Dr. Yunus Mia.
Thank you very much, Chris, and good morning.
First and foremost, World AIDS Day. It's one that has been earmarked to create awareness, but also continue the process of drumming up support in effort to reverse the specter of HIV/AIDS. As Chief of Programs, Dr. Yunus Mia, I would love to begin with you. Just give me a state of affairs report when it comes to HIV/AIDS within the country and perhaps the context globally.
Okay, thank you so much, Chris. I think our viewers, thank you so much for joining us today on the 1st of December, the World AIDS Day. As we join the rest of the world in commemoration of this World AIDS Day, we stand in support for those that are living with HIV. We also stand in and make new commitments to the fight against HIV. HIV has been with us for the last 40 years in the country.
Sure.
And globally, we have a big number of people that are living with HIV. About 37 million people have been affected, are currently living with HIV. And in Uganda and Sub-Saharan Africa, this is where the biggest majority of people with HIV are living. Uganda currently has about 1.2 to 1.4 million people that are living with HIV currently. The majority of which are on treatment, and that's a big success that we would want to share with the rest of the world. And on the other hand, a number of other successes have been registered. We have managed to reduce the number of HIV infections that happen every year as a country. And this fight has been spearheaded right from the top of the country leadership, the response from the civil society and the response from the community in general. However, we have not yet reached where we want to be in terms of preventing the number of HIV infections. We still see new infections above what the level that we need and can accommodate as a country. On the other hand, we've also reduced the number of deaths. Since 2010, we were having over 80,000 deaths happening each year.
80,000.
Yes, and currently we've managed to bring down the number of deaths to at least 20,000. So that is big success, but nevertheless we still have a big problem.
Okay, wow. The picture is one that has a lot of hope colored over it, but the grim aspects continue to blight that particular effort. As a principal advisor, technical advisor, that's it, Dr. Kaziwe, there's a lot to chew on, especially when it comes to from the point of policy and rollout of interventions. How are we managing to create harmony between the interventions and the realities of the ground?
Okay, thank you, Chris. Like Dr. Mia has mentioned, we've made a lot of progress as a country, and this has been largely because of the leadership of the country, His Excellency the President, together with partners, to be able to reduce the number of new HIV infections and the number of HIV-related deaths, but also the HIV-related stigma. And as a country, we are working with several partners globally to attain the UNAIDS 95 goals. And for us to be able to track that we are making progress towards those, we use evidence from, you said, from the ground. Yeah. So together with the Ministry of Health, the AIDS Support Organization works with the districts and health facilities to measure the number of new people diagnosed with HIV, to measure the number of new people who are starting antiretroviral therapy, and then to also track how many of those are successfully suppressing the viral load. And then from the data that we collect, we are able to design interventions that address the gaps. So currently we see that we are making good progress as a country against the 95. The first 95 is to make sure that at least 95% of people living with HIV know their HIV status. And as a country, Dr. Mia has mentioned, there are about 1.4 million people living with HIV in Uganda, but only about 1.2 million know their status. So that is about 89% who know their status. So you have a gap of 200,000 who have not accessed HIV testing, and to get to know that they are HIV positive and then be able to access lifelong therapy. But in the second 95, where we look at making sure that 95% of those who are HIV positive are on life-saving antiretroviral therapy, that one we've done well as a country. About 96% are already on antiretroviral therapy, and that is commendable, and that is largely because of the leadership again, but also support from different bilateral and multilateral partners, the Global Fund, PEPFAR, that make antiretroviral therapy available freely across all health facilities. And then the final 95% is viral load suppression, that when you take the ARVs, they should reduce the amount of HIV virus in your bloodstream so that it's undetectable. And when it's undetectable, then the risk of death is reduced, the risk of opportunistic infections. But then more importantly now is the risk of transmission from a mother to a baby, from a spouse to a partner. So that's what we want to attain. And so we've put in place robust data measurement systems, and we keep tracking and then designing interventions that address the gaps.
Okay, the spectre of HIV/AIDS over the last 5 years, according to some very familiar with these matters, has been greatly affected by funding. The fact that the rich nations, many of whom do sponsor the initiatives under either PEPFAR or Gavi or anything else that we've been hearing as it goes on. Right now, it seems like we have to redesign budget processes in order to ensure we maintain as a country the amount of interventions that have been rolled out, but that is a hard one. I'd like the program's chief to just take us through what are the funding gaps right now that could be affecting these kind of intervention processes.
Okay, thank you so much. The HIV funding generally and has always been spearheaded by our donors.
Yeah.
And much of the services that we have talked about have been supported alongside the government of Uganda with funding coming in from different multilateral and bilateral donors right from the start of the HIV scourge. And as time has moved, we have seen an increasing call for financing from local systems, right from government taking on additional responsibility.
That's right.
And then also other sources within the local framework, including the private sector.
Yeah.
Now, strides have been made along this, and now we are seeing that for sustainability, to ensure that the fight continues, because while we talk about 2030 as the end of HIV, we want to end HIV, but HIV will still be there. What it means is that we must have sustainable ways in which we maintain the services that we need for those that will continue to be challenged at that particular point in time. So currently, funding across the care and treatment landscape is adequate, but there is a number of other interventions. We see that HIV is affecting specific, the biggest proportion of new HIV infections are happening in particular groups. We call them key and priority populations. We have seen effects on adolescent girls and young key and priority populations.
Key and priority populations.
Yes, and then we see they contribute globally about 70% of new HIV infections. And in Uganda, about 25% of new HIV infections are happening in these key and priority populations. These key and priority populations are like, they are people we interact with every day, but they, because of their social habitat and their social characteristics, they are at increased risk. Among them are the commercial sex workers. Then we look at men who have sex with men, we call them MSMs. And then those persons in prisons, those who inject drugs. Those are some of the groups where we see new infections happening. Now, these groups require specific interventions to be in position to address the risks they have. Now, to be able to design new approaches, to be able to have tailored interventions to meet their specific needs, there is need for financing. And gaps continue to exist. Give an example for adolescent girls and young women. We need to keep them in schools, which has been clearly shown that keeping girls in schools helps them prevent HIV by almost 50% if they get to complete. But then, if we must keep them in school, we must have the resources. Now, at a local level, how much are we able to do? The donors have specific programs. Like currently, we see the DREAMS interventions. We are seeing different modifications of the DREAMS interventions, supporting especially girls, both in schools and out of school. But the girls are so many. You find that you're covering certain districts, and then certain districts you do not have enough resources to cover all the girls that are vulnerable. So before we address these vulnerabilities, it is impossible for us to achieve what we would call an HIV-free society.
Okay. On Tuesday, the United Nations, UNAIDS to be very specific, launched what's being described as the Dangerous Inequalities report, and the executive director, that is our very own Winnie Byanyima, was very categorical in saying currently we are not on track to ending AIDS by 2030 globally owing to inequalities. Dr. Kazibe, what are these inequalities?
Thank you. Inequalities, to just simplify it, that someone needs a service, but then they do not get it. And then someone who may not need a service actually has it available to them. So we are looking at inequalities in terms of availability, in terms of access, in terms of acceptability. So are the services available to those who need them? Are they accessible to them? And are they available and accessible in a form that is acceptable to them? So why we now see a lot of disparity in the new HIV infections. We had about 54,000 new infections in HIV infections in 2021, and this was a reversal of the gains that we had made in the previous year, 2020-2019, where we had about 38,000. But then this huge growth in new infections occurred largely among adolescent girls and young women. And maybe that informs why this year's national theme is ending inequalities in that age group. So the question we are asking ourselves is, HIV prevention services available to adolescent girls and young women. And we know that our cultures, our social norms might be prohibitive to, let's say, a 16-year-old girl who would love to access maybe condoms or PEP or PrEP. And these are the barriers we want to break down. If I am a long truck driver, for example, I drive the truck from Busia, Malaba, all through to Juba. Is there a way that I can access HIV prevention services that is aligned or integrated with the kind of work I do? Because if during the day I'm driving the truck and I only get time to rest in the night, which health facility will provide me with the services that I need? If I am a 30-year-old female married to a 50-year-old male who is already HIV positive, and I am experiencing intimate partner violence and maybe sexual violence, I have forced sexual intercourse from my husband, how can I access services that will protect me from HIV, from acquiring HIV from my husband? So the theme is largely looking at the social contexts of the individuals that we've identified are acquiring new HIV infections and making sure that we tailor the evidence-based interventions that we already know to be able to protect them against HIV. So largely that's what we are focusing on this year. And we have a number of interventions that we are piloting and testing in different contexts. We have now peer-led models to be able to distribute HIV self-test kits to men who have sex with men, for example, or partners of HIV positive individuals. Yeah, so that they can test and then go to a health facility if the self-test turns out positive. We are initiating community-based models of care for those who might have trouble accessing health facilities because of their the different social contexts that Dr. Mia also alluded to.
Okay.
Yeah, thank you.
Well, this is a public health question, and the creation or rollout of robust initiatives is something that is well anchored to be able to take the country forward, but most importantly reach those that need these services. Service delivery is a great concern for the country to the extent that rollout of health centers is also debatable. Some people say they are far away from those that need them, but then there is the aspect of culture. Dr. Kazwe has just alluded to sex between men. In a society that is very, very livid when it comes to such conversations, how do these programs factor that in ensuring that particular segment of the population that is vulnerable and is increasingly registering many infections is attended to? Okay,
as a country, I think a lot of strides have been made to try and reach different subpopulations.
Yeah.
The reality I want to share with the general public is that what we are speaking about is evidence-based. The number of new infections are higher in these subgroups.
Yeah.
And these subgroups exist.
They do.
Whether we acknowledge them or we don't acknowledge them.
Yeah.
So if HIV continues to be in these subgroups, then the rest of us continue to be at risk. So what it requires of all of us as a country is to actually acknowledge the fact that the problem exists, and then ask ourselves, how best
do we
move forward? Now, it doesn't mean endorsement, and many people mix the two.
They misunderstand.
You misunderstand that by supporting a person who has this particular character, you are endorsing their character. But if you don't acknowledge that, then there's going to be a disconnect between what you intend to do in general, but also what this person risks continues to be. So in terms of what we can address as in service delivery, we want to make sure that the services that are available are able to reach these populations given their needs. When you're a health worker at a facility and you're providing services, if you provide them the normal way, some of these categories, like Dr. Andrew has mentioned, may not freely come out to seek these services. Then you ask yourselves, if you don't reach out to them, then what is going to happen? So now, when you design what you call a tailored approach for this particular group, you reach out to them, give them the messages, and help them live a healthy life without spreading HIV. At the end of the day, you benefit. So when we speak about creating an enabling environment and inequalities, we are looking at our inability to reach out to these populations, given their risks. And for us to reach what we would call epidemic control or eliminate new HIV infections, we really need to be able to close the gaps in those subpopulations.
Yeah.
So appreciating at a national level, addressing those laws and policies that inhibit an environment where these persons can access our services is a key priority. And then at community level, we have increasing stigmatization for different subgroups within the community. And at the end of the day, if a person in that group gets HIV, they can't come out because they know the community judges them. They know the community does not accept them.
Yeah.
And they stay out there, continuing to be a risk. Now, as a community, we have that responsibility. We have that responsibility to kind of have less stigmatizing ways. Not that we endorse, but we accept that these realities are there. And then we provide an environment where they can access care freely. I'll give an example. Currently, we run a number of special clinics called drop-in centers. These drop-in centers have been designed to create access of services for some of these persons we call key populations. The truckers, the commercial sex workers, and so on. The design is that they operate at times when these persons are most available to receive a service. Yeah. And sometimes the health workers are trained to tailor the messages to the social context of these groups. If a district, or if the political leaders, or if the community is not understanding of this, then that service won't be available. And at the end of the day, we neglect the fact that we must eliminate HIV in this group in order for everyone else to be safe. Yeah. So working together to ensure that most of our services are received without judgment at health facilities. They are received in the community without stigmatization, will help us move a long way towards achieving epidemic control.
That's right. Stigmatization, something that, of course, continues to blight efforts in reducing the incidence of HIV/AIDS infections. Stigmatization leads to discrimination. And that is down to the fact that over the years, to be seen as sick is something that was looked down upon. I would like Dr. Kazube to help me and, of course, the audience out there understand the nexus between the fact that HIV itself is rampant, but the incidence of AIDS is greatly reduced. In other words, you don't see so many people and you classify them quickly as suffering from AIDS because of the availability of ARVs. People have learned to thrive, not just to survive. How is that being considered when you roll out the interventions, the fact that people don't look sick, but they are?
Okay, thank you, Chris. People don't look sick, but they are.
Sorry about that. It could be.
May not be very accurate. Yes. Because but I largely agree with you because this has a historical background to it. At the time that HIV first came into the country, we didn't have enough diagnostic tools, and it was difficult for you to know your status early enough. Yeah. And like you said, people fell sick and a number died. And in the early 1990s, it was quite clear individuals suffered a lot of wasting, cough, and diarrheal disease that and a lot of discrimination. You didn't want to have a family member who had what they called the slim disease by then. The slim disease, you didn't want to associate with them. And this is how far we've come. That we had very high prevalence of HIV, very high spread, but also very high mortality and even morbidity. Morbidity is sickness, people who are falling sick because of the complications of having it. So the HIV destroys your immune system, then you get to AIDS. AIDS,
that cocktail of diseases.
Yes, cocktail. You love to call it a cocktail. It's a cocktail when when it is something else.
A lot of diseases you're susceptible to them.
A number of them. We call them the opportunistic infections.
Opportunistic infections.
Yes, but these have gone down largely because of the availability of antiretroviral therapy, which, like I mentioned, lowers the virus in your bloodstream, and then your immune system recovers. So the likelihood of the opportunistic infections and death is reduced. So now that poses the dilemma that you presented, that I will not look sick but carry the HIV virus in me.
That's right.
And this points to some of the clarification we need to make, that some people actually want to wait until they have symptoms of any of the opportunistic infections to get to know their HIV status. But we're telling them, no, we are way past that.
Yeah.
That now you need to know your HIV status. Go and get tested and get to know, are you HIV positive or negative? It's not wise for you to wait until the HIV has destroyed your immune system and you're developing opportunistic infections for you to get to know that I could be carrying HIV. Because when you allow the virus to multiply in your body, it is going to destroy your immune system to the extent that it will be more difficult for you to recover when we start you on the antiretroviral therapy. But worse still, you have higher chances of spreading the virus to your loved ones. So, and men, Chris, men do not want to test. So I want to appeal to men like Chris and myself, find out your HIV status, and then if you find you're HIV negative, then you can access interventions to keep you HIV negative. If you are HIV positive, antiretroviral therapy is available. You need to take your drugs so that you can live a normal life. Yes, so the appeal is for us to test because you may not be sick, you may not be feeling sick, but yet because you've been exposed to HIV in whichever form, you may have acquired the virus, and it's in there destroying your immune system until a later time, maybe a year later or 6 months later, when you begin experiencing the symptoms of disease. Yeah.
Wow.
Thank you.
Equalize being the theme globally. Uganda narrows it down to attend to adolescents and young women. And earlier on the morning show, we were talking to the prevention head at the Uganda AIDS Commission, and there was also an official from the network of people living with HIV/AIDS. The conversation was very, very poignant because they were able to share some of this information. But I was particularly touched by the fact that HIV/AIDS among children has significantly reduced as a result of the minimizing infections, mother-to-child infection. However, after that, what happens? Because when the 15-year-olds are listed as one of the people that are most registering these cases, then it means the transition from infancy to early childhood is not very far. 7 years, 8, you're into 15, or and then all of a sudden, what you survived, you head on with it. That is part of, I think it's a social construct on the programs that you roll out. This is more public health. How are we doing rather on that?
Yeah, I think, Chris, that's a very important element, especially for the time.
Yeah.
Yes. I'm sure you have already come across the fact that the young girls 15 to 19 years are 5 times more likely to catch HIV than their male counterparts.
All right.
And that's statistically true in Uganda.
Yes.
The new HIV infections are more than 60% in women between 15 and 25 years.
25 years.
Yes. So when we go out testing, we are finding more women having HIV than the men.
Why?
Now, that is the big question that we have all been asking ourselves. And it stems from the whole context we are talking about as inequality. In our setup, you find that women and women and men of the same age groups have different social pressures.
Yeah.
You find that the context in which they have to live on a daily are different. Girls in Uganda are less likely to complete school compared to boys for different social reasons.
Yeah.
And by having that disadvantage, then they get more risked towards behavior that increases their risk of getting HIV. When you look at informal employment, the girls are less likely to find employment than their male counterparts. Most of the jobs that exist, electricity and so on, are for the males in our context. And you come to realize that the girls have to also have needs. And at this particular point in time, they instead of finding work, they must depend on men for survival and for having money for their social amenities.
That's right.
Now, in the context, and then the element of gender-based violence, you find that boys and girls of the same age, girls tend to face more challenges around gender-based violence, early marriages, and so on. Now, all these social contexts put together increase the vulnerability of these girls in the different age groups. Now, we need to recognize as a country the social and cultural contexts that we live in and how they contribute to increasing the vulnerability of women and girls to HIV. And if we must be in position to reverse that, then we ask ourselves, what's our role? I think I'll end there for now.
All right. There is the aspect of sustainability of service delivery. Many times government intervention is piecemeal. It's something we alluded to a little bit earlier when it comes to the distance between those that need the health services and the health centers. Government itself would want to roll out these services as effectively as they must, but of course funding gaps come into play. And then you spoke about the fact that the private sector has also been brought on board to be able to be a source of funding. Doesn't this take away the responsibility in the African setting? We know when the government understands that somebody else is doing something, then they can channel the money elsewhere, whether legally or illegally. Isn't that affecting how we are fighting the disease?
I wouldn't think so. One, maybe to just give you a background to it, that at the time HIV came, it caught everyone unawares. Yes, it caught the government unawares, it caught individuals, communities unawares, and our president has been commended for the leadership. And you may remember the ABC campaigns at that time, when we didn't have the ARVs in place. And there wasn't much hope that we would have antiretroviral therapy available universally. And so the American government has been generous and together with a number of multilateral partners to set up the PEPFAR. You've heard of PEPFAR, the President's Emergency Program for HIV/AIDS relief. But the word I want you to draw you to is the E, the emergency. Yes, so it was more of an emergency response. Can we reverse this preventable mortality from HIV by making ARVs universally available to everyone who needs them? So in the early 2000s, we then saw the ARVs coming on. But at the time that ARVs were becoming available, everyone was skeptical. Everyone was worried about how to manage these new drugs, their side effects, the supply chain. How do we ensure there is adequate stock for everyone? Because this is lifelong therapy. So if you're going to put me on ART today, you need to be assured of my next month's supply, my next year's supply.
That's right.
And so that is the work that partners, non-government organizations and other multilateral organizations have done with the government. And now we say the epidemic has matured in the sense that we have put most of the people who need ARVs on treatment, and we have largely stable supply chains, but threats remain. For example, the recent COVID-19 pandemic, where we had restrictions to access of drugs and the health facilities, and no wonder we had now the spike in new HIV infections. But then now, talking sustainability, now that the emergency phase seems to be coming to an end, can we then graduate these services to the government so that they are integrated into routine public health services. So as we move the treatment and testing to government, and so government has committed resources to this, but also in partnership with the private sector. The Uganda AIDS Commission is leading on this. You've probably heard of the $1 initiative. We're trying to see, can we have adequate local resources to continue sustaining individuals on treatment? And then can we mobilize additional resources to address the vulnerabilities that Dr. Yunus has alluded to? So it is not a danger. It is part of the process, because it was a shock when it came in. Now we have learned how to manage it and how to prevent, and we now have tools. The drugs, the ARVs are available. So now we are moving into the next phase where the government takes over 100% of the program, and then as the non-government organizations, we continue to support government to enforce accountability for the resources that we receive, and also to continue to break down the barriers of the different subpopulations.
Okay. In the early days of the pandemic, excuse me, seem to be grappling a little bit with an infection, but I was reading here when I wrote the story of Luka. This is a rapper, GNL Zamba. He says it became an educational tool for public health organizations. It was and still one of the most relatable peer-to-peer cautionary tales, but also therapy for our loved ones that had already caught the virus. How are the interventions of people like artists, the entertainment industry, helping what you're rolling out?
Yes, I think that's a very important element, especially when we speak sustainability.
Yeah.
For us to sustain the response, ordinary Ugandans and the community needs to appreciate the role they play, both at individual level and also at community level. Much of the response has been donor funding, donor interventions. Yeah. We design interventions, the donors fund them. Now, when we start thinking about how communities can be engaged in this response, then it becomes owned by these communities. And even when funding reduces, or even when you have innovations, you have already innate will for these interventions to be scaled up. Interventions like peer models have worked for the different populations. Currently, government in the HIV treatment guidelines and prevention guidelines, Ministry of Health rolled out the different peer models in which individuals affected with HIV, categorized in the different categories, are trained to actually be in position to have tailored messages. They have tailored approaches and responses, including delivery of treatment to their peers. So in so doing, you find that the health workers, who are few, can be in position to attend to those that need the service the most, and then those peers provide part of the safe element of care that they can be able to relate with their specific subgroups. Now, when you talk about the musicians and other social groups that come together, these play a very important role in increasing awareness, creating the messages that are most fitting to the populations that they relate with. You come to realize that for 30 years, the same message doesn't work. When we started, we were creating fear. I mean, there was fear, everyone was scared, so the messages were of fear. But now people seem to be accustomed to the messages. And now the young people, the different social groups, you find that
Is it the AC?
If musicians and other persons of influence in communities joined the fight and put up messages that are tailored towards specific groups, the growing number of youth relate so much with current trends. And what musicians usually do is ensure that their messages are tailored to the language and social acceptance of these particular groups. And if they do it in terms of in form of entertainment and mix it with what is relatable, then it becomes a much more easier message for that time when it is most required. So it is a key element in the current drive, and part of sustainability is to increase engagement of communities in their different forms. Part of sustainability is to ensure that the response is actually taken on at community level, including community-led monitoring and accountability for the services that the persons receive. Feedback needs to be provided from the communities themselves upwards towards the service providers to ensure that the services actually meet the needs of those that they are intended to reach out to. And in the current setup, I think another group that becomes very important are the community leaders. Once the different subgroups of community leaders appreciate where we are in the HIV fight, then it becomes easier for them to get mobilized. They become a source of information across every element of the social fabric. Yeah. Every time they're engaging with their fellows within their realms of influence, that is religious leaders, you can talk about political leaders at LC, you can talk about social influencers on social media, you can speak about all these different social groups. Wow. It becomes easier because they know the psyche, they know the reasoning, they know the groups that they are interacting with. Okay. And then they have the will of the people to be listened to. Yes, so thank you so much. All
right, I'll come to the principal advisor, Dr. Kaziwe. Climate change and the climate crisis is something that is blighting efforts, or it's affecting much of what is going on. I do not know beyond the interventions. I was reading the other day about Mildmay and what is doing beyond HIV/AIDS awareness, because if a community, for example, has the ability to get on, especially when it comes to the activities that can help drive awareness, it might not necessarily be AIDS related, but it has a long way in educating and galvanizing the kind of cooperation from a community. Why am I asking? Because so much funding is going into climate-related issues, then the weather patterns are affecting especially the women who are in agriculture. These women need ARVs, and it could, for example, affect their ability to get the drugs in time. When it comes on the technical aspect, how do we factor in aspects like climate change and the crisis and everything around that could affect the HIV/AIDS fight?
Yes, thank you very much, Chris. And that is a pertinent question that we are now discussing with a number of stakeholders. We have learned from the COVID-19 pandemic that the progress we have made with ending HIV can be rapidly reversed by a single threat. So when you talk climate change, we now see that global warming is causing changes in weather patterns, and these changes in weather patterns affect the what we call food security. So you find that you're going to have a change in seasons, and when you have a change in seasons where you have a country like Uganda where our agriculture is largely based on nature, really. We do not have a lot of artificial irrigation to supplement what we have. Then food insecurity arises, and food insecurity, would you rather swallow your ARVs or look for food? And it becomes a debate for the individual to choose between the ARVs and food. And we've already seen this in semi-arid regions of the country where individuals drop off their ART care in search of food, or because they couldn't find food. More importantly, the climate change also changes the kind of pathogens that we are dealing with, or germs that we are dealing with. So some pathogens multiply faster, some germs multiply faster in certain weather conditions. And so the issue of now global health security becomes very pertinent. So from the technical perspective, these are the discussions we are having with government, that can we have in place interventions that prepare communities, that increase the resilience of communities against changes in weather patterns. Can we also implement climate friendly interventions? You have especially tree planting is like the easiest low-hanging fruit that we can hang on.
That's right.
And we've also seen floods and landslides affecting access to antiretroviral therapy care. The other day I was interacting with colleagues from Bukwo and the eastern side of the country, where you probably heard that story, where floods, the burst of a riverbank carried off colleagues who are providing antiretroviral therapy services.
Yeah, sure.
Yeah, so this is the reality that we are dealing with. That yes, we have made gains in making HIV testing, HIV prevention, HIV treatment services available, but these gains can be easily reversed by natural or man-made disasters. So now the question we need to ask ourselves is, have we prepared ourselves to meet those disasters, and are we putting in place enough measures to prevent those disasters from happening, but more importantly from impacting the gains that we've already made? Yeah, so that's what we are looking at, and it is going to inform a lot of the national policy, but also funding arrangements from the different multilateral partners.
Okay, thank you very much, Dr. Kazue. As we enter the final bend of this particular talk show, allow me give you the opportunity to do what will be our wrap with regard to the call for action from the government and other stakeholders, especially in light of 1st December. It is a day that so many conversations have been triggered. There are so many people in boardrooms. There are those in the fields. There are also those making noise on social media about this particular issue, but it could end there. There are concerns about lip service, no doubt about that. So the call to action, how should it be designed? Who should we listen to most, especially when it comes to what to do and how we are going to achieve most of the objectives that government is rolling out?
Okay, I think from this discussion, I want to emphasize a number of things. The HIV epidemic is still here, but the light is there. We can still reach 2030 and achieve the goals that we set out.
That's right.
We can end the epidemic. And to end this, we need to address issues of inequality. We need to be able to reach out to all those that are at risk, those that we have left behind, and catch up on the gains that we had made prior to the COVID-19 pandemic. To do this, government needs to be in position to play a number of roles: increase financing to the HIV sector, increase engagement, especially with the different stakeholders for sustainability. In the area of those that are vulnerable, the young girls and women, the interventions that are there are clear. We need to be in position to garner support and funding to sustain girls in schools. We need to be able to mobilize those that are out of school to also receive some form of education, some form of support, to be resilient, to be in position to take care of themselves. A lot of programs are going on at national level. Some of them are supported by different donors, Global Fund, USAID, through the DREAMS projects. And the goal of this is to increase their capacity to understand the impact of HIV to them, but also build their resilience against the epidemic. And that's a very important element, because if we don't address that, it will become an increasingly big problem. For new HIV infections will become, will get a new source that will be these adolescent girls and young women. So the programs that we implement at program level, and that is those that are in the healthcare sector, we need to increase our capacity to recognize these differences, tailor services that reach out to these different subgroups, the key and priority populations, and these interventions need to be provided without stigmatization. They need to be provided with elements of equity, where we design them to reach out to these groups and target them, rather than create the one umbrella or one service fits all. We reach out to differentiation of services, such that the groups that are most affected are able to be reached in the right time.
All right, Dr. Mia Yunus, the Chief Programs and Capacity Development at the AIDS Support Organization. Many thanks for those last words. That will do as a wrap for this particular discussion. And of course, many thanks to you too, Dr. Andrew Kaziwe, Principal Technical Advisor at that is Medical Services at the same organization, TASO. It's been a pleasure having your company here, and of course sharing some of the insight and perspectives as the country joins the rest of the world in marking World AIDS Day, 1st December. I do hope that the messages that are being disseminated across by all stakeholders will be taken seriously, and of course you'll be part on an individual basis of what is no doubt a long and protracted effort to reverse the spectre of HIV/AIDS in the country. I am Chris Higenyi. It's been a pleasure having your company. Normal programming continues. Do stay with us.